Good morning, good afternoon, good evening from all around the world, and welcome to day two of the Congress. And this is the second session of day two, which is going to be a great one, I am sure. And it is creating a novel research program, a case study from the National Bleeding Disorders Foundation from the United States of America. So I am your technical lead from Task Op. My name is Dapo, and I'll be helping facilitate this session. And I'm going to introduce our moderator, Andrea Trinidad, who will then introduce our wonderful speaker today, Dr. Michael Recht. So, Andrea Trinidad is the president of Hemophilia Advocates Philippines and a passionate voice for people with rare bleeding disorders. She lives with von Willebrand disease and hemophilia A, and her own experience has shaped her deep commitment to patient rights and access to care in the Philippines. Andrea began her career as a journalist, covering national news for the Philippine Daily Inquirer. Today, she serves as an editor for International Business Times UK, where she continues to tell stories that matter on a global scale. Alongside her journalism work, she's also a communication strategist, helping organizations craft campaigns that inform, inspire, and drive change. An unexpected chapter in her life led her to Palawan, one of the world's most beautiful islands, where she now runs a small bed and breakfast. What started as a passion project has grown into a space that welcomes guests from around the world with warmth and heart. Balancing advocacy, media, and entrepreneurship, Andrea brings people together through stories, strategy, and sincere connection. Whether in the halls of policy, across digital platforms, or over coffee on a quiet morning. So thank you for being with us, Ms. Andrea Trinidad, all the way from the Philippines, and we are glad to have you here. So I'll hand it over to you.
Good morning, everyone. Good evening, good afternoon, good evening, wherever you are in the world. And welcome to the Patient Partners track here at the Third International Congress on Sickle Cell and Other Inherited Blood Disorders. We are very honored to have here with us Dr. Michael Recht, a leader who has helped shape the landscape of research and clinical care for bleeding and clotting disorders. Dr. Recht currently serves as the Chief Medical and Science Officer of the National Bleeding Disorders Foundation, where he guides the organization's um, scientific vision and research strategy. He is also a professor of clinical pediatrics at the Yale School of Medicine and a pediatric hematologist at Yale New Haven Children's Hospital. He is caring for children and young adults with bleeding and clotting disorders. Before joining the National Bleeding Disorders Foundation, he held leadership roles as Chief Executive Officer of the American Thrombosis and Hemostasis Network and as Director of both the Hemophilia Center of Oregon Health and Science University and Mountain States Hemophilia Network. Over his distinguished career, he has participated in more than 110 clinical trials, many focused on new therapies and gene therapy for hemophilia, placing him at the forefront of global efforts to bring hope to future generations. Ladies and gentlemen, please join me in welcoming Dr. Michael Recht.
Thank you very much, Andrea. Really pleasure to be here today and to talk about a 6-year effort we've been going through at the National Bleeding Disorders Foundation, where we are building a new paradigm for how clinical research is done in the inheritable bleeding disorders field. As Andrea said, my name is Michael Recht. I am a pediatric hematologist at Yale Children's Hospital, and I also am the Chief Medical and Scientific Officer of the National Bleeding Disorders Foundation, formerly the National Hemophilia Foundation in the United States. Here are my disclosures. I am on the board of directors of an educational organization, a nonprofit educational organization called Partners in Bleeding Disorders. If you want to see the content of that organization, the website name is partnersprn.org. So here's what we're going to talk about today. I'm just going to give a little bit of background on the National Bleeding Disorders Foundation, talk about the evolution of the National Research Blueprint, which led to our Lived Experience Expert, or LEE, Research Ambassador Program, which has ultimately evolved into the Bleeding Disorders Research Collaborative. The National Bleeding Disorders Foundation is dedicated to finding cures for inheritable blood and bleeding disorders and to addressing and preventing the complication of these disorders through research and education and advocacy. The main part of our mission is really about enabling people with these conditions and their loved ones and family members to thrive. So let's talk first about the National Research Blueprint. Like I said, this is the culmination of about a 6-year effort where we've had this initiative to build a transformational research enterprise, and we've done this through engaging the entire community. And as we were thinking about how research was done at the time of starting this endeavor and how we envision research to be done as we evolve this idea, we really wanted to think about how research was approached and rethinking how we prioritize research and prioritize it for issues that matter to people who are living with these disorders. I'm at that part of my career now. I've been doing research in inherited bleeding disorders for about 30 years now, and I can look back at the very earliest studies that I've done and say, huh, I wonder why that question was interesting to me, because when I talk to people who have inheritable bleeding disorders, it might not be that interesting to them or that important to them. So what we're trying to do with this new approach is to make sure we're asking questions that are important to our lived experience experts, people living with inheritable bleeding disorders, either having them or being family members or caretakers. We also want to democratize the research culture. So it's no longer going to be a top-down where the doctors and the research are the ones thinking about the questions, designing the studies, and then telling people with inheritable bleeding disorders how to participate. We want to start this research endeavor from the ground, from the people with inheritable bleeding disorders. And then we want to completely transform the way we share the outcomes. When I give in-person talks about the National Research Blueprint, particularly to advocacy groups or consumer organizations, I ask the question, ask people to raise their hands, how many people have participated in a research study? And in the United States, we have research studies going on all the time, so a lot of people will raise their hands. And then I ask the follow-up question and say, how many of you know the results of the research study that you were involved in? And almost all the time, all the hands go down. So we are building something that we will make sure that everybody knows the results of the studies that we are going to be moving forward with. So we envision a research world where people with inheritable bleeding disorders thrive, and that begins with research that is inspired by our community. The mission of this research effort is to advance an accessible standard of care and quality of life for everyone who's impacted by these conditions. And this is going to happen through collaborative and meaningful scientific inquiry, through a coordinated and efficient research infrastructure, and is going to be undertaken by a representative workforce in partnership with an engaged community. And all of this is grounded in principles of health equity, diversity, and inclusion. So let's talk a little bit about where we've started and where we are right now. Really, the first phase of this effort started all the way back in 2020 and 2021, right at the beginning of the pandemic, where we had what we called the research state of the science. We wanted to figure out where things stand with research in inheritable bleeding disorders, how research was done, and what worked and what we could make better. We ended up having a virtual meeting in September of 2021. We had about 400 participants in that meeting. Leading up to that meeting, we had various working groups. Working group on hemophilia, working group on von Willebrand's and other mucocutaneous bleeding disorders, working group on women with bleeding disorders, even if they had hemophilia or von Willebrand's. We knew that there were topics that were specific for women and girls and people who have or had the potential to menstruate that we had to pull out from the generalized disease specific working groups. We had a working group on musculoskeletal issues. We had a working group on equity, diversity, and inclusion. Those the results of that were presented in this summit we had in the late summer, early fall of 2021. And we published a group of articles that were written by all the people who were part of this. Those articles are available and they're open. There's no paywall to get to them. And that's an expert reviews in hematology in 2022. We'll talk more about how the state of the science evolved into the National Research Blueprint, but that happened in 2022. We had another summit in January 2024 after all the work that went into the National Research Blueprint. We dug much deeper. Excuse me, I'm getting over a cold from my grandson. Um, I apologize for that. Although I'm not infectious through the internet, so everybody's safe. Um, and again, we are working on the articles from that January 2024 summit right now. We just got the peer reviews back from those, so we hope that those will all be published within the next 2 or 3 months. And then since 2024, we have been working to implement what these working groups have put into place. So this is just another way to look at where we've come. You can see we started at the very beginning with National Bleeding Disorder Foundation's former CEO, Dr. Len Valentino, who is also a pediatric hematologist, but has since retired, but remains intimately involved with us. He started by working, developing this blue sky vision, and he spoke with focus groups that included people with inherited bleeding disorders, their loved ones and family members, industry, providers, researchers, payers in the United States, and asked the question, what can we do better and how can we do it? And let's think about it not in with any kind of monetary restrictions, but if there were no restrictions at all, how can we do this best? That included some in-person workshops that involved all the members that I just talked about, including government partners. And then we had the State of the Science and the National Research Blueprint summits. So out of the State of the Science came this idea of a lived experience expert. So what is a lived experience expert? Excuse me for a second. Lived experience expert is a name that was created by people with inheritable bleeding disorders, their support groups, their loved ones, their family members. And as part of that packet of papers we published in the Expert Review of Hematology, Esmeralda Vasquez, Michelle Kim, and Maria Santaella, uh, all the first two people who have bleeding disorders. Maria is the director of the vice president of research at the National Bleeding Disorders Foundation, and formerly was a nurse at a hemophilia treatment center in the United States. They wrote this editorial about how the name lived experience expert was created and how it has become socialized. In the United States, this term Lee or lived experience expert has really been taken up by everybody. When we talk to our government partners now, the people who help fund our treatment centers, when we talk to some of the other research organizations, some of the other advocacy organizations in the United States, lived experience expert or Lee is a term that has become completely socialized, and it all started with the people that were involved in the working groups that helping us develop this new paradigm of research. So in order to have our lived experience expert have as greatest impact as possible with working with our researchers, we had to develop this a training to help people who might not have a scientific background learn about science, learn about creating clinical trials, learn about recruiting and participating and writing and interpreting and disseminating clinical trials. So we're calling this our research ambassador training. And you can see here that there are really 4 different levels of a lived experience expert research ambassador. The outer circle, or the most common um, type of involvement, is someone who's aware of research. They read about research maybe in the news, they attend some meetings where people talk about research, and they read plain language summaries. People who want to take the next step, we're calling research users. And these are people who are able to read research reports, who are able to discuss the results, and can talk about these results with their healthcare providers, with their peers, and think about how these research may impact them personally and how they help with family decisions. The next level is the research participant. The research participant is someone who actually participates in research, just like the name says. They complete surveys, they complete polls, they are members of listening sessions or focus group. They can contribute personal data to registries. They respond to interviews, and they actually can participate in an interventional study. And finally, with this training we're developing, we are hoping to create research leaders. And these are people who are going to advocate and help fundraise for research, who are going to be champions for research to their peers in their community, who are going to assist with participant recruitment, who are going to help create and disseminate study communications, to serve on steering committees, or help advise bodies such as the Institutional Review Board, which is what we call our ethics boards in the United States, and then actually eventually co-lead a study as a principal investigator. So not only do we have to train the lived experience experts, but we have to train the researchers on how to work appropriately with lived experience experts. So this research training is going to focus on meaningful lived experience expert engagement in research and mentorship and support. So we are going to help our researchers understand how lived experience experts can engage in research by focusing on transparent communication and mutual respect, by incorporating input from our lived experience experts into their research design, by engaging the lived experience experts as true partners, not just someone that is sitting on committee, not just someone who is a participant in a research study, but someone who is partnering in the data collection, in the data analysis, and helping disseminate or get the results of the research out to the community. One of the things we found out is we really have to help our researchers acknowledge that there is an implicit power differential. So we need to get away from this paternalistic um, approach where we, as the doctors, we, as the researchers, are saying to a person with a specific, in this case, inheritable bleeding disorder, this is what you need to do. And instead, listen. And instead, hear. And instead, embrace our lived experience experts as true and impactful partners in everything we're trying to do. And like I said before, even though in the United States, this idea of equity and diversity and inclusion is not supported by our current federal leadership, we at the National Bleeding Disorders Foundation are in this to ensure that every single person who has inheritable bleeding or blood disorder is represented, is heard, and is uh, part of what we're trying to build. So let's talk about where we've moved to the National Research Blueprint. So, like I said, we've had this evolution. The National Research Blueprint has evolved into what we're calling the Bleeding Disorders Research Collaborative, or the BDRC. There are three guiding principles of the Bleeding Disorders Research Collaborative. The first is mutual respect between the researchers and providers and the lived experience experts. And what does that mean? That means we are going to act with boldness, but the flexibility to achieve innovative solutions without making things complex. We're going to work collaboratively to pursue both incremental growth on research, and we've decided that we are no longer going to do what we're calling one-off projects. Have a researcher think of one little question and do it without involving the rest of the community. No more one-off projects. Everything's going to be done in collaboration. And we know that we're not going to be perfect. So when things don't work, we're going to celebrate what doesn't work, but we're also going to celebrate our successes, one voice, using our learnings to fuel the network and move forward. And we're going to examine and mitigate the presence of both conscious and unconscious bias. If we are mutually respecting each other, that leads to our next principle of genuine collaboration. And this means that we're going to base our partnerships on trust and the respect for dignity for everyone. And that means collaboration and engagement with our diverse multidisciplinary stakeholders, having everybody on equal footing, including those from minoritized and historically marginalized populations, to ensure that we, as the provider and the researcher, include as well as inform and guide meaningful research. And with this genuine collaboration, this means we're going to end up with effective interpersonal interactions, meaning we're going to engage our partners with humility and competence and embrace uncomplicated, transparent communication through active listening. Now, as a pediatrician, this seems so intuitive to me, right? Because there's no way if I'm sitting in a clinic room and I'm listening to a child or listening to their parent, then I'm going to be able to um, effectuate change unless I listen. But that's not true in all parts of medicine, and particularly in the United States, where there is significant paternalism going on, where we haven't yet clinically or in the research field, reach this ideal of our guiding principles. So through the State of the Science and through the Bleeding Disorders Summit, we came up with 9 spanning research topics that were identified by our lived experience experts and by our researchers and multidisciplinary working group members that they thought were what we needed to concentrate on. And what we have decided is that basing these 9 spanning research topics makes it look like we're growing a tree, right? So each one of these topics, how to improve the lives of lived experience experts, how to figure out how to mitigate the impact of bleeding, how to figure out why female bleeding is different than the bleeding we see in men, uh, long-term joint and bone health, having a real ability to look at lifespan, right? In because of the HIV and hepatitis crisis with hemophilia clotting factor concentrate back in the late 70s and early 1980s. Um, we didn't have old people with inheritable bleeding disorders. So we're starting to get old people, right? I'm 63. Um, there are very few people who are 63 years old who have hemophilia in the United States because of the toll of HIV and hepatitis that occurred. We are going to look at the mechanisms of bleeding and the complications and treatment response. We're going to look at the immune response. Why do people get inhibitors? Uh, we're going to try to figure out a better way to diagnose inheritable bleeding disorders, right? We are in 2025, and I can tell you in my clinic, there are people who clearly have bleeding disorders that I can't give a name to what they have because we just don't have the best diagnosis yet. And because we don't have the best diagnosis, that means we don't have the best treatment. There are still some people in the United States with unidentified bleeding disorders who are being treated as if they, are in the 1950s, right? They're getting plasma because we don't know what else to give. They're in hemophilia. We have gene therapy now. We have emicizumab. We have the new rebalancing agents that are available. So the therapeutic choices for hemophilia are incredible. But some of our rare bleeding disorders or unidentified bleeding disorders, we don't have uh, adequate therapy for right now. So these 9 spanning research topics really are what was identified by our working groups that included lived experience experts. And you can see the 9 branches of the tree encompass these 9 spanning research topics, and the smaller branches are scientific areas of interest, and each one of those leaves or I guess different colored blood drops on the tree indicate a specific research priority that has been identified. So this is a slide that is trying to show exactly how we're going to evolve what we're doing. On the far left is that tree that I just showed you with the various research working groups. In the middle is what we're calling our clinical research consortium that is in a hub and spoke model that extends right into the community, where we're talking about the translation on clinical research endeavors. We're going to be able to budget and finance and create contracts to do this research. We're going to build the network and the resources that are required to do this type of research. We will have data safety monitoring boards, and we will have a central designated institutional review board or ethics community to make sure we are protecting the health and safety of our lived experience experts or the people participating in the research. And we are going to do this by creating these cross-cutting committees that are going to talk about how we're going to develop our workforce and the leadership in this field, how we are going to continue to mentor and train researchers, how we are going to involve our lived experience experts, all based on Health Equity, Diversity, Inclusion, which is what HEDI stands for. I apologize for that acronym. It's not incredibly well known, but I was running out of space when I was creating the slide. Using everybody to help create protocols and protocol resources in clinical trial design, and then using all the tools that we have available now, the genetics, all the different proteomics, bioinformatics, to to develop questions and studies that are going to be as robust as possible. So I think about how we have as most impactful involvement of our lived experience expert, like this big funnel. So at the very top of the funnel, we solicit research proposals. And those proposals can come from clinician and researchers, they can come from lived experience expert. MASAC stands for the Medical and Scientific Advisory Council, which is the committee of the National Bleeding Disorders Foundation that puts out guidelines on how to best treat people with inheritable bleeding disorders. Uh, Everybody gets thrown into that hopper when we solicit research proposals. We then work with various groups to take the concepts that are put into the top of that hopper to create protocols. Those protocols are then refined and budgeted and eventually implemented, and that leads to active studies. So, what's the potential impact? What does this actually mean for our community? So, Ray Stanhope is a gentleman with hemophilia who is the president of one of the chapters of the National Bleeding Disorders in the state of Texas in the United States. And he has been integral to what we've been building with the lived experience expert. And this is a quote from him: "No more one-off research. Having lived experience expert input, guidance, and insight at every level of the National Research Blueprint, or now the Bleeding Disorder Research Collaborative, will make research in our community better and more applicable to all." And I couldn't agree with Ray anymore. If we are successful in what we're trying to build, we are going to have faster progress to meet unmet needs. We are going to develop novel insights from this integrated data. We are going to have important direction from our lived experience expert voices. And we're building this mechanism to take something that we learn and build on it quickly to accelerate something from discovery to being an actual therapy. And we're going to do this as efficiently as possible. And that way we will learn as we grow. So this is my last slide. I hope people can see this. It didn't come out as well as I was hoping, but really what this is intending to show is that this really is a blueprint. And if you think about that entire building as the Bleeding Disorders Research Collaborative, you can see that the foundation of everything we're trying to do is built on the idea of health equity and diversity and inclusion and accessibility and belonging. We are trying to create the largest community that we can so everybody has access to being part of research to move a field forward. The different columns include research and development and in community engagement and making sure we develop the workforce. Believe it or not, in the United States, because of the goofy reimbursement paradigm, we're having trouble with maintaining young, involved hematologists, mainly adult hematologists, pediatric hematologists, not as bad, because adult hematologist makes about half as much money as an adult oncologist. So it has been difficult for us in the United States to maintain the appropriate workforce to keep our field moving forward. We're building the infrastructure. I didn't get into the infrastructure that we're building for this kind of research collaboration, and it's all going to be based on policies and priorities. And if health equity, diversity, inclusion is the foundation, the roof, the protection of everything we're doing is the lived experience expert, and that all ends up with our Bleeding Disorders Research Collaborative. So in summary, the National Bleeding Disorders Foundation, we are committed to equitable health access and innovative solutions for all. Because of that, we are creating a new multidisciplinary, multi-institutional, lived experience expert-centric research collaborative that's based on health equity, diversity, and inclusion principles and is going to have impactful inclusion of lived experience experts at every step of the process. And I am so happy that I got this invitation to talk at the Gansets Congress because we at the NBDF are interested in partnering with all organizations to expand this effort internationally. Here's my contact information, my email address at the NBDF, my cell phone in the United States. Please feel free to reach out and text or call me if you want to talk about this. Email me. Um, I look forward to talking to everybody, and that is it for the slides. I really look forward to um, some fruitful discussion.
Thank you very much, Dr. Recht, for that very compelling presentation. So it's very interesting. It's the first time that I heard of the term um, Lee, the living experience expert.
Yes.
And it's really, I think, you know, uh, a wonderful concept. And what you've shared with us today truly reframes how we think about research in inherited bleeding disorders. And the national blueprint that you were talking about is not just a scientific roadmap, it's a movement towards a more inclusive and community driven future. And it's really, really exciting. And, my takeaway is you reminded us that for so long, research has often been a top-down process, but you were mentioning about the um uh hold on, let me check my notes, the ground up. Yeah, so and science, it used to be that we just listen to the doctors. It's always the doctors telling us what to do, but then with this concept of listening from the patients, the caregivers, it's really gonna change, especially for developing countries. We're still far, far from there, and I'm learning a lot from you today. So, because what we are used to is the scientists usually ask questions, design the studies, share the results, but it's not always what people most affected, it's not always with people most affected. So this new paradigm does is flip the structure, through the inclusion of lived experience experts. People with bleeding disorders, their families, the caregivers now help define what questions matter most. So co-create studies that was at you what you mentioned earlier. So it's really a very inspiring vision, one that blends science, empathy, and empowerment. And as Dr. Recht mentioned earlier, and he emphasized, it's all grounded in health, equity, diversity, and inclusion. Okay, so now at this point in time, I think we're now opening to the to questions. We can take in questions from everyone. There's actually already one question here. It's from Riyadh Albard and is asking, are we as patient community, where should we be in terms of meaningful patient engagement on research design? What could be done to get to that goal?
Hmm. Yeah, that's a great question. I really appreciate that. I think that in many countries, including my own, that the idea that the lived experience expert has any uh, impact on the questions being asked in the research field has been sort of a foreign concept. And if we think about it from starting from the lived experience expert perspective, just talking to your provider, talking to your treatment team, that's going to open a lot of eyes, right? There are people that just haven't considered this as a potential. So it all begins with talking, and hopefully the provider or researcher is going to be open enough to listen, to hear what people have to say and think, wow. I mean, like I said during the talk, I can look back on my own list of references and say, huh, why did I mean, that was a question that was really interesting to me, and I did these studies. Um, but when I talk to my patients or parents, they're like, well, yeah, not that important. That doesn't really impact my kid's life. Why don't you do research on, this? And that's really helped me visualize this type of paradigm. It really came out of the mind of our former CEO, Len Valentino, who many people know internationally. Like when I walk through a Congress with Dr. Valentino, it's impossible to get from one side to the other because he's like the mayor of inherited bleeding disorder. He shakes everybody's hand and he knows everybody. And um, but it was really Dr. Valentino's thoughts, and then Maria Santaella, who's the vice president of research at NBDF, who brought this idea to fruition. And it all starts with talking and listening.
Right, talking and listening. That's very true. Okay, so we have another question here from Ruji Chalos. I'm not sure if I pronounced the name correctly, but they said here, Dr. Rex presentation brings a number of realities in perspective. As an advocate, caregiver, and a friend, where people living in with inherited blood diseases confide in me and do not want to speak out because they are exhausted as a result of dealing with their pain, and also don't feel like that they are being heard. How do I communicate their voice?
That is such an important question. And, my hope is as the treating community evolves and moves away from the perspective of we, the treaters, know what is best for you, instead of we, the treaters, need to hear from you to figure out what is you consider is the best for you. I'm hoping that we're going to see some evolution in that perspective. That might just be rose-colored glasses, right? I hope I'm not being overly enthusiastic for what I'm seeing as part of um, a mentor for our young trainees. My boss at Yale told me the other day that he considered me to be a radical optimist. And I said, "Oh, thank you." And he said, "No, that's that's not a compliment. You've got to be more realistic." And so I understand that it's super easy for me to say, "Go talk to the provider will listen." As someone who's getting older, who now unfortunately has to access the healthcare system more frequently, I know I have providers that don't listen to me. So I get it,
Mm-hmm.
but I think the only way it's going to work is by continuing to, particularly as a representative or as an advocate, is to be strong and keep that message consistent and continual and in front of the providers and researchers.
Very, very, very true. And I guess we really have to also train the advocates, like have more advocates for the community so that they are confident in voicing up what they really experience. Okay, we have another question here. As a patient advocate, what is the patient defined threshold for minimal clinically important difference for a new gene therapy in terms of quality of life improvement? And how does this contrast with purely clinical measures like annualized bleeding rate?
It's, I am so glad you asked that question. My daughter is in the last 6 months of getting her PhD in kinesiology. I don't even know what kinesiology was, but she's studying head impact in um, athletes. And she is using many of the different PROs, looking at depression and anxiety and pain in athletes who played in high impact sports versus athletes who were in non-impact sports. And she's writing up her thesis right now and has all these incredibly interesting results showing the difference of people who have these chronic subconcussive head injuries on the difference in depression and anxiety and pain, but she's basing them all on statistical significance and didn't look at minimal clinically important difference. And her research mentor had never even heard, because he's not a clinician, had never even heard of minimally important, clinically important difference. So I'm helping teach them about this very important concept. So that's a long preamble to get into. The gene therapy trials were designed very interestingly. I was involved in both the Roctavian trial and the Hemgenix trial and the Spark trial that didn't move forward, but is now moving forward again. And they are looking at um, annualized bleeding rate. They're not even looking at factor level as their outcome. They're looking at annualized bleeding rate, and that is really driven by the regulatory agencies. The regulatory agencies are saying we are only going to improve something if we can show a statistically non-inferior bleeding rate with current therapy. But that's not what the people who are getting these gene therapies care most about. And what I'm hearing as a gene therapy investigator is not only do I not want to bleed, because, if I have hemophilia A, I don't bleed a whole lot on emicizumab anymore, or some of the newer products, or even on the longer acting like Altuvio that we have available in the United States. Um, so I don't want to think about hemophilia anymore. That's my goal with gene therapy. So that's where we have to, as researchers and people designing these trials with lived experience expert input, have to come up with trial designs where we meet what the regulators want us to show, but we also meet what the people who are participating or thinking about receiving gene therapy want to show. We did publish, excuse me, we did publish the PRO results at 18 months on the Hemgenix trial, Hope B, that looked at etranacogene dezaparvovec. Um, and they were very interesting. At first pass, it looked like some of the PROs, patient-reported outcomes, such as the EQ5D5L, which is sort of an internationally validated measure of pain and anxiety and activities of daily living. It looked like there was no difference pre and post gene therapy. But when we were writing this up, what we commented it on was this trial happened in the middle of the pandemic, and the entire world's EQ5D5L scores went down, and the people on the trial stayed the same. So it looked like we had no impact, but really, compared to the rest of the world, who was having a pretty crummy time being in the middle of a pandemic, the people who underwent gene therapy were doing pretty well.
Wow, amazing. We have very little time, but I guess we I can ask you one more question. So this is from Surbi Mishram. How does this integration of LEE from individuals with blood disorders who simultaneously occupy patient, legal, and research roles reveal gaps, and what collaborative models can strengthen patient-centered research and policy reform?
That is such a complicated question and such a good question. It is something I think about every single day. So we, even going all the way back to the beginning, what is the definition of Lee? Can someone with an inheritable bleeding disorder who is a hematologist and a researcher, is that person still a Lee? And at first, the non-medical, non-research people who were part of this Lee panel said, no way, you know too much, you can't be a Lee. But we evolved and if you've got a bleeding disorder or blood disorder, you're a Lee by definition. So we do have people in this working groups that we have that fill different roles that have a bleeding or blood disorders, who are researchers, who are advocates. And I think personally that strengthens what we're trying to do. Um, so, so to answer the question directly, um, how does this strengthen patient-centered research? I think it is because of that diversity of endpoint, that diversity of opinion, that diversity of baseline knowledge, and then our attempt to build everybody up to be as strong as possible. If that's what someone is interested in, I think it's only going to benefit what we're trying to do.
Thank you so much. I would like to ask more questions, but we don't have time anymore. So thank you so much, Dr. Recht, for your time and for all the insights that you have given to us.
Yeah, my pleasure. My contact information was there. Please feel free to reach out. I'd love to hear from people. Thank you, everybody, for attending today's session. Thank you, everybody.
Thank you.